and be brief.
Yes, sir.
So that we can have a lot of exposure to the hypersexuality talk.
Absolutely.
I'll be brief and premature also.
only for this topic, okay?
Yeah. Pawan, do we have the slides?
Yes, sir.
So, good evening to all of you. It is our pleasure to host Nilesh Shah, sir. Welcome to the 29th edition of Thursday Musings. Next slide. We have our chairman, Dr. Tufan Pati, sir. He's a professor of psychiatry from Qatar, and he has asked me to be very brief. So, sir, I am handing over to you.
Thank you, Alim. I would be a little less brief. We have, first of all, I shall introduce our moderators, the vibrant, always vibrant, Dr. Amrit and Dr. Alim. Dr. Amrit Patujoshi, who is a professor and chief consultant neuropsychiatrist at High Tech Medical College and Amni Hospital and Healing Touch Clinic. He is a direct council member of IPS. He is the editor of Odisha Journal of Psychiatry, which is indexed. And Dr. Alim Siddiqui of Lucknow, Nawab Alim Siddiqui. He is Director of Healthy Minds, Neuropsychiatry and Behavioral Sciences Center, Lucknow, a visiting professor of psychiatry to ERAS, Lucknow Medical College, and he is the ex-direct council member of IPS, and he is the finance secretary of IMA Lucknow branch and IAPP UP UK chapter of Indian Association of Private Psychiatry. And we have got two equally vibrant chairpersons. We have quite a young team. Dr. Ranjan Bhattacharya of Parampur. He is affiliated, is associate professor and HOD of Department of Psychiatry, Murshidabad Medical College, Barampur, West Bengal. West Bengal Medical Education Services is official recognition. He is working under West Bengal Medical Education Services. He is director of Charak Square Diagnostic and Research Center. His areas of interest is addiction psychiatry, sexual medicine, child and adolescent psychiatry. That is why he is here. He has 52 publications, and he is winner of Bombay Psychiatric Society Silver Jubilee Award and IJCMA Award. He is a life fellow of APA, IPS, IAPP, and IAGMH. Welcome, Ranjan. And we have with us Dr. V. Judge Reddy. He is from Kakatiya Medical College, Warangal, and his consultant psychiatrist, Healthy Brain Clinic and Hospital, Secunderabad. He is currently president of IAPP, Telangana State Branch, treasurer of Telangana Private Psychiatry Hospitals and Nursing Home Association. He is past president of Hyderabad Psychiatric Society, founder and past honorary general secretary of IPS Telangana State Branch. His areas of interest: substance abuse and addiction, child psychiatry, ADHD, autism, intellectual disability, rehabilitation and liaison. Psychiatry past experience is consultant to psychiatrist for National Institute of Mentally Handicapped in IMH Secunderabad, honorary consultant to WHO in the field of rehabilitation. Welcome, George. Welcome.
Thank you,
and
sir.
with this, I hand over the meeting to George and Ranjan, the vibrant chairpersons of today, who will take on from me. Welcome.
Thank you, sir. I'm audible?
Yeah.
Yes, sir. First, at the outset, I would thank Dr. Tufan Pati, sir, the chairman for the program, the Thursday Musings, and Dr. Amrit Bhai and Dr. Alim Bhai. And I think you people are really doing a wonderful job. And definitely, thanks to IPS and IPS Odisha State Branch. Indeed, I was just trying to look at how these topics were selected. Definitely, thanks to COVID, in a sense, I think we are able to come together on this virtual platform. But more important is, I think by this kind of platforms, there are so many new things which are being brought up to be discussed, and where our colleague psychiatrists are going to definitely be benefited. And today's topic, hypersexuality, by Dr. Nilesh Shah. I think, sir, definitely, I think you're doing a wonderful job bringing up so beautiful topic. I think in our day-to-day practice, we come across many times, we wonder whether it is a symptom or whether it is a diagnosis entity, Not to go to details of the topic, sir. Definitely, I think we are having a good crowd, and definitely it will benefit our daily practice. I request my friend Dr. Ranjan to introduce Dr. Nilesh Shah.
Thank you, Dr. V. George Reddy, consultant psychiatrist from Hyderabad, the most erudite, cordial, and knowledgeable person I have seen ever. Thank you, IPS Orissa State Branch, for giving me this opportunity to be the chairperson of the very important session. And thank you, Professor Tufanpati, organizing chairperson, Professor Alim Siddiqui, and Professor Amrit Parjosi, the organizing secretaries, who are bringing this program live. And this is the 29th edition of the Thursday Musing. It is my proud privilege and honor to introduce the person himself, who is the star speaker. And to just tell you the CV, he was the class monitor in the third standard. And as Sir told me that she had won the third prize in the running competition in the sixth standards. He also acted in a drama in the ninth standard. He is working in the Sion Hospital, Mumbai as a full-timer since 1988, as didn't get any attachment to other hospital as a consultant. He likes watching Hindi movies, traveling, and roadside food. Sir, me too. Married and has twin daughters, and his premorbid personality is over anxious. And he will be discussing on the topic that dealing with the hypersexual behavior.
There is another slide also.
Yeah, hypersexual behavior in clinical practice. So as we know that he has a various major achievements. He has more than 30 years of experience in the field of clinician and teacher. He has more than 90 publications to his credit in various national, international index journals, and he presented papers at more than 150 conferences, seminars, and symposium. Kudos to you, sir. Without much ado, I would like to hand over the microphone to Dr. Nilesh Shah, sir. So stage is all yours. We are eagerly looking for your wonderful deliberation. Over to you, sir.
Please unmute yourself.
Yes.
Yes.
Thank you very much, Ranjan, and thank you very much, all of you, Dr. Tufan Patti and Dr. George Reddy, Dr. Amrit Joshi, Patta Joshi, Dr. Alim Siddiqui. I'm very happy to be over here, and I'm very grateful, particularly to Dr. Tufan Patti for inviting me and giving me this opportunity to present on this little unusual topic. Dealing with hypersexual behavior in clinical practice. I'll just share my slides. Okay. So in our clinical practice, we come across a number of patients who show hypersexual behavior. And the way we have, say, difficulty in falling asleep, insomnia and hypersomnia, excessive daytime somnolence. Similarly, we have hyposexuality, that is decreased desire to indulge in sexual activities, and hypersexual behavior, that is increased desire to indulge in sexual activity. Now, in fact, in DSM-5, there was a group who wanted to make this as a clear-cut disorder, and this could have been a definite entity, a separate entity in DSM-5, but it did not come as a regular entity, and they had already devised the criteria for hypersexual disorder. So some of the criteria for hypersexual disorder, the independent disorder by itself, was over a period of at least 6 months, recurrent and intense fantasies, sexual urges, and sexual behavior in association with 4 or more of the following 5 criteria. So they had criteria, but basically it was recurrent and intense desire, fantasies, sexual urges, or sexual behavior. And it had to be repetitive behavior, and it would cause significant personal distress and also impairment in social and occupational functioning. And there were specifiers. So hypersexual disorder can be excessive masturbation, excessive indulgence in pornography, excessive sexual behavior with consenting adult is also considered as hypersexual disorder, cyber sex, telephone sex, strip clubs, etc. So variety of things were stated. Now, clinically, we see hypersexual behavior in number of disorders, and it can be, as Dr. Siddiqui mentioned, it can be a symptom in variety of disorder, or it can be disorder by itself. So the way we have primary insomnia or primary hypersomnia, similarly, you can have only hypersexual behavior disorder or hypersexual disorder. What I'm going to present is I have come across in my clinical practice hypersexual behavior in variety of situations, and I'm going to present few cases. We can see hypersexual behavior in manic patients during bipolar mood disorder, manic episode. We have seen in patients having acute stress reaction, major depression, generalized anxiety disorder can also have sometimes hypersexual behavior. We know cluster B personality indulging in hypersexual behavior, and it can be a behavioral addiction. Nowadays, we talk about behavioral addiction. So internet addiction and similarly, sex addiction. It can be seen in patients with dementia or post-head injury, what we call disinhibited behavior, disinhibited indulgence in sexual behavior. And many medications and hormones can also cause hypersexual behavior. So let me start with some of the patients in whom we had seen this hypersexual behavior, and it can be seen across the different age range. So right from young people, children, to adolescent, adults, and even senior citizens, you can see hypersexual behavior. So let me start with 2-3 cases of mania in which we had seen this hypersexual behavior. We had this young boy, 11-year-old, and he was a known case of ADHD and was brought by his mother with history of change in behavior since last 2 to 3 weeks prior to the consultation, in the form of over familiarity, particularly with females in the family, neighbors, peers, and class teachers. Repeatedly saying LUHQKU, that is love you, hug you, kiss you, and asking females to give him a hug and a kiss. Now, this behavior was very, very different than his ADHD behavior, and many times we are able to differentiate that children with attention deficit hyperactivity disorder, they are hyperactive, they are running around, they are inattentive, but usually they do not indulge in this kind of sexual behavior, and this kind of behavior was very, very different than his earlier behavior, which was diagnosed as ADHD. And when we saw the behavior, when we saw the patient, we could make out that he is having lots of mania, symptoms of mania. And then we had to treat early onset mania, and gradually with olanzapine, sodium valproate, other antipsychotic drugs, etc., he gradually improved. And then again, his manic episode subsided, and then again he had that ADHD behavior. So in children, sometimes it may be a little difficult to differentiate between ADHD and manic episode. But since we knew that child and the parents also knew that child, and this was a change in the behavior, and hypersexual behavior is usually seen in manic patients, not in ADHD patients. And his behavior was obviously hypersexual, going and hugging everyone, telling everybody that I love you, I kiss you. So we could make out. So this is 11-year-old boy who had an episode of mania and hypersexual behavior. We had this 24-year-old female. Her name was Honey. Honey's husband had to cut short their honeymoon as he could not meet with Honey's insatiable demand for sex. On inquiry, it was learned that she had a past history suggestive of mood disorder, and she had stopped medication a few days before her marriage. Now, this is a very, very common experience that patients who have psychiatric disorder, schizophrenia, bipolar mood disorder, or even for that matter, depression, they do not want to tell the opposite party at the time of marriage that they had a psychiatric problem, because then their chances of getting married decreases. So here they did not tell the husband that she had a bipolar mood disorder, and she got married, and obviously she was she was normal at that time of marriage. Husband got married, and because of the marriage she had stopped the medicine. And it so happened that immediately after the marriage, when they went on the honeymoon, she started going into the manic phase, and she started asking for repeated indulgence in sexual behavior. Husband tried to satisfy twice a day, thrice a day, 4 times a day, but finally he got so tired, and then he had to cut short his honeymoon and say, yes, I understand that we are on honeymoon, but I can't go on like this. I can't fulfill your insatiable demand for sex. And then when they came back, it was revealed that she had this manic episode because she had stopped the medication. But again, the presenting symptom was hypersexual behavior over here. The way you can see this manic episode, hypersexual behavior in young patients, 11-year-old patient, 25 years old patient, adult patient. We had one 67-year-old patient, Dhondiba, who was admitted in orthopedic ward with multiple fractures following assault by a group of women following hypersexual behavior. In Mumbai, these dabbawalas are very, very famous. So he was a dabbawala, and he used to carry the lunch boxes from home to the office. And he was very nice. Everybody knew him, and he never had any past episode of this mood disorder. But first episode at the age of 67. And when we talked to the relatives, we came to know that there was a history of change in behavior since about 2 weeks prior to the admission. One fine day, this Dhondiba, who was a typical dabbawala, always used to be clad in white pant, white shirt, and white cap, suddenly changed his attire, and he brought himself a pair of jeans, a t-shirt, a pair of glares, pair of short shoes, sport shoes, and he started singing and dancing, started teasing women, and on provocation, he would become very angry and irritable. And one morning, the women had lined up to fetch water. So he went there and started teasing them. And at that time, this song, "Tu Cheez Badi Hai Masta Masta," was a very famous song. So he told some women that "Tu Cheez Badi Hai Masta Masta." Obviously, they got very, very irritated, though got angry with him. And he was bitten up black and blue. He had multiple fractures. He ended up in hospital, and he was in orthopedic ward. And there also, his manic symptoms did not subside. So he, even after that assault, he was shouting and singing, and to nurses, he was very over familiar. "Hi, sister, come here," kind of thing. And then psychiatric call was sent, and we realized that he had this manic episode. And again, the presenting feature was hypersexual behavior, for which he was beaten up. So one of the most common disorder in which we see hypersexual behavior is bipolar mood disorder, manic episode. It is also seen not only in mania, but also in depression and acute stress reaction. We had this 17-year-old boy from orphanage, and he was very, very upset and in tears as he was unable to get his mind off the thoughts and images throughout the day and even during sleep of the blue film which he had watched a week ago. So in orphanages also this kind of situation occurs. All the boys are alone. They are in the common room, and obviously they are 17 years, 18 years. So anybody from 12 to 18 years, they have this desire to indulge in sexual activities, and somebody kind of smuggled in kind of blue film, and it was very first time that he watched this blue film, and after that he was feeling very guilty. He was ashamed of himself for watching it, and constantly he had this blue film coming in front of his eyes. Even in dreams he kept on seeing this, and he was very distressed by this continuous film going in front of his eyes and in his thoughts. And it was exactly like an acute stress reaction where you relive the traumatic experience. And though for most of the other children, watching blue film is a pleasurable experience, for him it was a traumatic experience. And we had a diagnosis of acute stress reaction following exposure to a blue film, which he kind of felt it was very traumatic. And then we treated him with medicines, counseling, and then over a period of 3 to 6 weeks, he gradually improved. Similarly, we had this another 28-year-old boy, Romeo of red light area. He was a computer engineer, and he presented with complaints of severe anxiety, feelings of restlessness and discomfort since about last 6 months. He also expressed intense overriding desire to visit red light areas almost every day in spite of knowing about its hazardous consequences. When we examined him, he had severe anxiety, depression, guilt feeling ashamed, but he said he cannot stop and he's feeling terribly depressed, and at the same time, he gets this intense desire to indulge in sexual activity. He tries to control himself, but he's unable to do so, and then he has to go to these red light areas and indulge in sexual activities. And obviously it was a hypersexual behavior, because almost every day he was visiting, which was not his usual thing. And we realized that he had severe anxiety, depression. Maybe he had this behavioral addiction kind of thing also. So again, we started antidepressant, treated him, and gradually as he recovered from his anxiety, depression, there was a improvement in this hypersexual behavior. So it was a symptom of his depression. As I mentioned, that obviously mania and acute stress reaction depression we see very frequently in our clinical practice. Similarly, we see patients of personality disorder, particularly what we call cluster B personality disorder, antisocial personality disorder, borderline personality disorder. And there also we see this kind of hypersexual behavior. And hypersexual behavior is not only restricted to men, but even to women. Sometimes you can have hypersexual behavior. This 34-year-old housewife was brought by her husband as he scandalously found her sending lewd SMSs and her own nude photographs to some of her male friends by MMS and emails. On detailed inquiry, it became evident that she had a borderline personality disorder, and she used to indulge in this type of behavior when her husband would go abroad for days together. So when we asked her, she said that when the husband is around, she has a relationship with her husband and she is able to satisfy her sexual desire. But when the husband is not there, she gets this intense desire to indulge in sexual activities. Sometimes she is able to fulfill those activities with masturbation, but many times she has this intense excessive desire and she gets preoccupied, and at that time, to satisfy this behavior, she has to kind of call some of the friends, male friends who may be interested, and then send them sexually toned SMSs material. And then finally she also ended up sending her own nude photographs to them. And obviously she had personality disorder, and we tried treating this personality disorder. It's very difficult to treat these patients. She came for follow-up, and then husband became more vigilant. Husband said, okay, now I will be little more careful. And he said if there is an option, whenever he has to go abroad for work, he will also take her along with her. We have seen addiction, and we know very well about alcohol addiction, cannabis addiction, drug addiction. Similarly, nowadays we talk about behavioral addiction. And in this behavioral addiction, we had this Ravi, 24-year-old male patient, who sought consultation for his preoccupation Ravi, 24-year-old male, sought consultation for his preoccupation with internet pornography. He was spending many hours each day watching blue films on internet. For this, he had tried antidepressants, group therapy, individual psychotherapy. He had found out on the net there was some Sexual Addict Anonymous and counseling. But things were not working out for him. He was not able to get rid of this addiction, which repeatedly throughout the day, whenever he had access to computers or mobiles, he had to watch this pornography, and he was himself becoming aware that he is developing kind of addiction. So one of the things which we use nowadays for behavioral addiction is naltrexone. So we started him on naltrexone 50 milligram and then increased naltrexone to 150 milligrams per day, 50 milligram 3 times a day. And his preoccupation with internet pornography decreased. After a few days, when he was better, he thought that he will discontinue naltrexone. He discontinued, and again he started excessive urge to watch this pornographic medicine. And again he requested, and we again restarted naltrexone again, and then he was much better. As an added benefit, he also realized that with naltrexone, he had better control over his binge drinking as well. So later on, we also found that he had this alcohol binge drinking pattern, and he found that even that also he could control well when he was on naltrexone. So if you have this kind of addiction, one of the medicines which we can use is naltrexone. Sexual addiction can also be seen in elderly patients, and I had this 72-year-old retired music teacher, and he sought psychiatric consultation when the servant boy working in his house started blackmailing him and demanding money for fondling him. When I talked to him, he said that he had inability to resist the temptation to fondle young boy servants working in his home in spite of his best efforts and in spite of being fully aware of the dreadful consequences for last couple of years. And he was elderly person. He did not have much relationship with his wife. He did not have anyone else to fulfill his sexual desire. And then he had somehow developed this liking for young boys who were working in his house, and he would call them near to him, pay them 50 rupees, 100 rupees, fondle them, kiss them, and some of them would allow. And this time he got into trouble because that boy started telling him that if you don't, if that gentleman did not give him money, he will kind of spill the beans, tell everyone, and started blackmailing him when he thought that he needs a psychiatric consultation, and he came to us. Obviously, he had this excessive sexual desire. One of the medicines which we use for this kind of behavior is either you can use naltrexone, as I mentioned in the earlier case, or medicines which increase prolactin level and decrease the sexual desire, like risperidone, or more than risperidone, amisulpride. And sometimes the other medicines also can be used to reduce the excessive sexual desire. We know that in dementia, head injury, you can have disinhibited behavior, and they lose their control when they get desire to indulge in sexual behavior. We had again this 67-year-old gentleman who was referred from a daycare center and he was repeatedly indulging in masturbation in the center in full public view without any hesitation. When we talked to him, he explained that he was deprived of love by his wife, and the staff of the center did not allow him to visit toilet frequently. There was some history of cerebrovascular accident and some cognitive deficits after cerebrovascular accident, and he had excessive desire to indulge in sexual activity. And earlier what he would do, he would go to this daycare center and then visit, go to toilet repeatedly, go to toilet, again try to masturbate, feel good about it, again come back, do some activities, again go to toilet. And the staff thought that why is he repeatedly going to the toilet? So they stopped him going to the toilet. They said only once or twice in an hour you can go to the toilet, you can't go. So then he could not control his desire, and he started masturbating in front of everyone. The simple thing was to tell the staff of the daycare center that yes, he has this hypersexual behavior. We are going to put him on some medications to reduce his hypersexual behavior. But in the meantime, he has this idea that he can go to the toilet and indulge in hypersexual behavior, do some masturbation. So we requested the staff that allow him to go to the toilet, and then he can indulge in hypersexual behavior, fondling his genitals, and he doesn't have to do it in full public view. And that was a relief for him as well as for the staff of the center. Hypersexual behavior has also been reported after the head injury, and here is a report of 2 cases of Kluver-Bucy syndrome following severe traumatic brain injury. And they have tried SSRIs like escitalopram or fluoxetine in this kind of behavior, what they call Kluver-Bucy syndrome, where after the head injury, both the amygdala gets affected, the person becomes very tame, docile. There is a hyperphagia, excessive eating, pica, they start eating whatever they see. Hyperorality, they put everything in the mouth. And one of the another symptom is hypersexuality, sexual stimulation from unusual, inappropriate objects. And many times they kind of pick up a dog or a cat or some animal and they try to have sex with that animal. Also, they have visual agnosia, inability to recognize familiar objects or people. And according to the report, these patients pose significant management problem until successfully managed with SSRI. So even SSRI, we know that sometimes can reduce the excessive desire to indulge in sexual activity. And in this kind of patients, they have found SSRI to be useful. And finally, we have medicines, what we can call as iatrogenic hypersexuality. And we have to be very, very careful about it, because then we prescribe some medicines which induces hypersexual behavior, and the patient will be in trouble because of us. And if we do not recognize this and do not stop that medicine, it can lead to major problems. We had this middle-aged couple referred by a gynecologist as wife developed intense and rapacious desire to indulge in sexual activity after she was given some hormones. They were staying in a single room with their 3 children and were hardly indulging in sexual activities for last few years. And a couple came to me, and wife very categorically said that after taking some hormones, which was prescribed by the gynecologist, because she had some problem, menstrual cycle disturbances, etc., she had immense desire to indulge in sexual activities. And she would keep on telling her husband that she has this desire, but because they had 3 children in the house and there was no privacy, they were unable to do it, and this was causing lots of distress. The simple thing, we had to tell the gynecologist to change that hormonal treatment, stop that hormonal treatment, and that immediately after stopping that hormonal treatment, she got relief. It is not necessary that all the patients develop this kind of behavior, but sometimes, rarely, this kind of phenomena occurs. Interestingly, lamotrigine, the drug which we use very, very frequently for bipolar depression, can also indulge, can cause hypersexual behavior. Here is a report of 2 male patients exhibited acute hypersexuality while taking lamotrigine as an add-on therapy. One patient on carbamazepine and one on oxcarbazepine. Neither had prior history of psychiatric illness nor brain damage predisposed them to such a response to treatment. And in both the patient, the hypersexuality was not a part of hypomania or more diffuse psychiatric disturbances. In the first case, hypersexuality resolved after discontinuing lamotrigine therapy without any concomitant treatment. In the second case, a reduction in the dose of lamotrigine decreased the intensity of hypersexuality and contributed to patients' increased satisfaction with his sex life. So we have been using lamotrigine very frequently. And if after starting lamotrigine, if the patients develop hypersexuality, we might think that patient is going into mania or it's a manic episode, but we also might have to think that if in the absence of other symptoms of mania, it's only hypersexuality, then we may consider lamotrigine-induced hypersexual behavior. Similarly, interestingly, in elderly patients, we frequently use donepezil. And there are case reports of 2 elderly females, 81 and 72, who after starting tablet donepezil, 5 milligram at bedtime, very small dose, developed overwhelming preoccupation and urge to have sex many times in a day and frequent masturbation. And on stopping donepezil, symptoms abated a few weeks later. Now, just imagine that 81-year-old female comes to you or brought by some relatives, you put them with for cognitive deficits donepezil, and that lady starts indulging in hypersexual behavior. Obviously, relatives are not going to like it. And if we know that, oh, donepezil induces this, we can immediately stop donepezil. But if we are not aware, then once in a while, that behavior will continue and we might end up increasing the dose of donepezil thinking that this is disinhibited behavior because of dementia. Similarly, many times for decreased sexual desire, we add aripiprazole. And for excessive sexual desire, we add amisulpride. Amisulpride increases prolactin and inhibits the sexual desire. Aripiprazole decreases prolactin level and increases sexual desire. So reports of hypersexuality symptoms in 2 female patients with schizophrenia who were receiving treatment with aripiprazole. The patients experienced more frequent sexual desire and greater sexual preoccupation after taking aripiprazole. There is a report of 28-year-old male patients after several psychotic episodes, he was switched to 15 milligram of aripiprazole. He developed an addiction habit for gambling at casino slot machines. Under treatment, he switched to homosexual behavior with hypersexuality, unprotected sex, and sadomasochistic practices. The craving for gambling and compulsive sexual behavior ceased 2 weeks after aripiprazole was discontinued and he was switched to amisulpride. Thereafter, he reported a return to a heterosexual orientation. Such an interesting case, rarely reported. Many times we might have seen this, we might have missed this. And a simple rule to remember, aripiprazole increases the sexual desire, amisulpride decreases the sexual desire. Amisulpride increases prolactin level, and that's why it decreases sexual desire. And many times patients who have hypersexual behavior, amisulpride rapidly improves that hypersexual behavior, as in this case. Not only hypersexual behavior, but little kind of gambling behavior and unprotected sex, homosexual behavior were all seen. Probably a little bit going into mania. But then his diagnosis was a psychosis, not a bipolar mood disorder. Has anyone else experienced almost manic-like symptoms when they go off their SSRI way too fast? This was a question by one of the patients, and she had mentioned it. I went off Effexor, that is venlafaxine, way too fast, and I have hypersexuality. And what is weird is that even though I get sad and have brain zaps once in a while, I get a surge of emotional excitement and euphoria. I'm assuming that since serotonin is like a brake pedal on dopamine, that my brain is firing off dopamine more so than a normal brain level. Not only this, woman has expressed her experience of suddenly rapidly stopping venlafaxine, which is an SNRI. Though she has mentioned it SSRI, actually it's an SNRI withdrawal. And sudden withdrawal of SSRI or sudden withdrawal of SNRI can increase dopamine, because we know that SSRI can kind of little bit inhibit dopamine release, and sudden withdrawal can release excessive dopamine, which can cause little excitement, emotional excitement, little euphoria, and also can cause excessive hypersexual behavior. So hypersexuality can be a part of sudden SSRI or SNRI withdrawal symptom. Similarly, those medicines will either increase dopamine or dopamine receptor agonist can have a pathological hypersexuality behavior on dopamine replacement therapy in a patient with progressive supranuclear palsy. This 83-year-old man with PSP was being treated with carbidopa and syndopa for Parkinsonism, for progressive supranuclear palsy. Sometimes people put on syndopa for 8 months. Due to nausea, the syndopa was replaced by low-dose medicine and medopar and bromocriptine. For the following 2 months, pathological hypersexuality, sexually suggestive remarks, touching, kissing, disrobing, exposing genitals, facial flushing, penile erection, public masturbation, he slowly developed. At this point, his serum testosterone level was normal, whereas serum prolactin level was very much suppressed to almost 1.3 nanogram per ml. And that was because of bromocriptine probably. His pathological hypersexuality completely disappeared 2 weeks after discontinuation of bromocriptine. Bromocriptine, as we know, is a dopamine receptor agonist. After 4 weeks, pramipexole, another dopamine receptor agonist, was added instead of bromocriptine since his motor performance deteriorated. After 1 week of pramipexole, all the hypersexual symptoms also re-emerged. So at this point, his serum prolactin level was 2.2 nanogram per ml. So particularly in patients with Parkinsonism, and I think pramipexole we also use sometimes in bipolar depression. So when we use medicines like bromocriptine or pramipexole, we have to be little careful and watch for hypersexuality induced by these medicines. And if it so happens, simple thing is to withdraw these medicines. His pathological hypersexuality completely disappeared again just by discontinuing pramipexole. Then he was titrated to medopar up to 125 milligram, that is something like syndopa 3 times a day, instead of adding another dopamine receptor agonist. After 3 weeks, his motor performance improved with partial re-emergence of hypersexual symptoms, which was penile erection, facial flushing, sexually suggestive remarks, touching. However, the severity of these re-emerged symptoms was much more tolerable than those induced by dopamine receptor agonist. And again, his prolactin level came up to 13.3. So that was not a much problem, and it was controlled. Finally, there is one little controversial thing which I came across while reviewing the literature. for some of the patients for hypersexual behavior, particularly in elderly people, we have used ethinyl estradiol, a medicine which is available in India as Linoral, 0.01 milligram once or twice a day. This is estrogen, ethinyl estradiol, and this also reduces hypersexual behavior. I came across this case report, anti-androgen, cyproterone acetate therapy in a deviant hypersexuality, and they have used this kind of chemical castration to control the hypersexuality. A psychopathic male with uncontrollable and deviant sexual behavior, homosexuality, incest, fetishism, transvestism, was treated with androgen using cyproterone acetate 100 milligrams per day for 3 weeks. So very, very high dose of cyproterone, which kind of inhibits testosterone completely. After 4 days, the plasma testosterone level basal 9 a.m. and 6 p.m. and during masturbation, pre, immediate, post and 30 minutes post had dropped by approximately 50%. So you inhibit testosterone by this therapy. Clinically, both erectile and ejaculatory capacity and libido, that is sexual feeling, tension, fantasies, were reduced, the former to a much greater extent than the later. Both clinical and endocrine effects were completely reversible 8 weeks after discontinuing the medicine. 2 other cases studied clinically showed complete suppression of sexual responsiveness, physiological and libido on doses ranging from 50 to 150 milligram per day. And these effects were also reversible on stopping the drug. In addition to the action on sexual feelings and functioning, all patients noted general tranquilizing effect. So now the thing is, should we use this kind of treatment in patients who are multiple offenders, many times indulge in hypersexual behavior, incest, rape? And if we see this as a deviant hypersexuality, which because of which they indulge into this kind of behavior, by and large, they will be picked up by the police and they will be behind the bars. But if we see this as an illness, and if we can treat them with anti-androgen drugs like cyprosterone, ethically, are we right? Whether we can do this, whether ethically it is wrong. So that's a point for discussion. So finally, we see this hypersexual behavior in number of conditions. It can be primary hypersexual behavior, and they will kind of get the diagnosis of hypersexual disorder the way we have primary insomnia or primary hypersomnia. Hypersexuality itself is a behavior, it's a hypothalamic symptom, or it can be a drug induced, or it can be a symptom of many other psychiatric disorders like dementia or mania or depression or acute stress reaction, or it can be a part of personality disorder, as I mentioned by presenting few cases. Obviously, counseling is very, very important, explaining them that yes, they are not 100% responsible for their behavior, and this changes in hormones or because of the mental illness, they may indulge into this hypersexual behavior, and not to feel ashamed of it, not to feel guilty, but take treatment and come out of it. Similarly, behavior therapy can be done for some of the hypersexual behavior, particularly when it is a behavioral addiction. Then certain principles of behavior therapy can be used. Various psychotropic medications have been recommended. SSRIs, as I mentioned, particularly in elderly patients, head injury patients, or post-stroke depression patients, or post-stroke disinhibited behavior. Escitalopram, citalopram, paroxetine, sertraline have been tried. Antipsychotics, which increase prolactin level, decreases desire to indulge in sexual activity. So risperidone, amisulpride, and our age-old thioridazine, which we use for Ghat syndrome. You know, people come with nightfall, and they want to stop. We give thioridazine and it stops. It also reduces their anxiety. hormones like estrogens, ethinyl estradiol, linorol, 0.01 or 0.05 milligram, one tablet. We have tried this in some of the patients, but one has to be little careful because it can cause gynecomastia, and that is one of the side effect of long-term use of ethinyl estradiol. The way long-term use of amisulpride or even risperidone can cause gynecomastia in some patients. Anti-androgen drugs like cyproterone, which blocks the androgen receptors. Can we use this? Has anybody has some experience with this? We do not know, but it's a little bit debatable thing. LHRH agonists like goserelin has been suggested induction. I have no idea, no knowledge about this. I came across one report of cimetidine, 300 to 800 milligrams per day for hypersexual behavior. I don't know much about it. If anybody has experience with that. Obviously, at the end, if somebody wants to ask, sir, what is your sexual preference? How frequently do you indulge in sexual behavior, whether it can amount to hypersexuality? Is there any guidelines that once a day or once a week or once a month? My sexual preference is simple, as often as I feel like indulging in that behavior. So thank you very much for this opportunity, and I come back to the group.
Yes, sir. Thank you.
Thank you very much, sir, for your wonderful deliberations. Really, you have explored all the aspects of the hypersexuality as you started with the various case vignettes, and it's a very interesting and scaffolding in a one by one. You have started with a patient with a manic symptom, acute stress reaction, as well as a personality disorder, a case described as ADHD, as well as the Romeo of the red light cases, so on and so forth. So we have received some questions. So I'd like to ask the first question that has been asked by Dr. Shantosh Gaur. He asks that recently came across a patient with Parkinsonism, and he has having the personality and hypersexuality towards his wife and other females in the home, including his daughter-in-law. He is very sensitive to even for overactive sexual behavior and how to manage this patient with Parkinsonism having the hypersexual behavior. Nilesh sir.
Yes, I think I would like to find out whether he is on any medication. It is quite likely that if he has Parkinson's disease, then probably he has been put on Syndopa or Pramipexole or Bromocriptine, any of these kind of medicines, and anything which increases dopamine or anything which acts on dopaminergic receptor can cause hypersexual behavior. So I think we will have to see whether hypersexual behavior was before starting the treatment for Parkinsonism or after starting Parkinsonism. What dose of Syndopa or Bromocriptine, Pramipexole is he getting? And if there is a temporal correlation that after starting a particular medicine or after increasing a particular dose, the patient has developed this excessive desire to indulge in sexual activity, the easiest thing is to cut down on that. If you feel that it is not related to drugs, then symptomatically you can give certain medicines. As I have mentioned, SSRIs have been found to be useful. Amisulpride has been found to be useful. Linorol, that is ethinyl estradiol, has been found to be useful. But before you do any of those things, drug-induced hypersexuality should be ruled out in patients with Parkinson's disease. Mute.
Thank you, sir. Dr. George, would you like to ask the next question to sir?
Yeah, I think Ranjan, you go ahead because I have some problem in seeing the screen.
Okay, fine. So, question asked by Dr. Ajay Kumar Saxena, sir. A lady with OCD had a compulsive desire to have the sex with her husband, and which is very anxiety provoking as well. So, how to deal the case? The patient with OCD with compulsive behavior has urged to have the sex with her husband.
Very, very interesting question and very interesting observation. increased sexual desire can, as mentioned, can be part of mania, can be part of depression, can be part of anxiety disorder. Similarly, here it appears that this compulsive desire to indulge in sexual activity, and it's a compulsion, and probably she might have certain obsessions, and to fulfill those obsessions, she has to indulge compulsively in sexual behavior, though she may or may not enjoy that behavior. By and large, in OCD, we have seen severe dislike for sexual behavior because they feel this is dirty, this is not good. So whatever OCD patient I have seen, usually the women have dislike for indulging in sexual behavior because, in quotes, it's a dirty thing to do. Interestingly, this case shows that excessive sexual desire can be seen in OCD patients also. I would suggest treat OCD very vigorously. It's difficult to treat cases, OCD as such. Fluoxetine, go up to 120 milligram. Clomipramine, go up to 300 milligrams. Anti-anxiety drugs, we usually use oxazepam, 30 milligram 3 times a day. And if necessary, you can add, already fluoxetine is there as an SSRI, and that does not control. You can add amisulpride. Amisulpride has also been tried, small dose antipsychotic. Sometimes we add in treatment resistant OCD. So that also can be tried. But primary, if you feel that this hypersexual behavior is a part of OCD, as a compulsive behavior of OCD, you treat OCD, and that compulsive behavior should come under control.
Excellent, sir. The next question asked by Dr. Challa Varati. She asked that what are the medical condition and drugs which can cause hypersexuality? You have covered most of the question, that most of the part, that the conditions and drugs. Can you elaborate little more about that? That what are the conditions, the medical condition and the drugs, the iatrogenic part? Over to you, sir.
Yes, drugs, as I have already mentioned, hormones can cause increase in sexual desire, particularly testosterone or certain hormones which suddenly inhibit estrogen can cause excessive desire in sexual excessive desire to indulge in sexual activities. Many of the medicines which increase dopamine level can cause hypersexuality. Any medicine which inhibits prolactin, so decreases prolactin, like aripiprazole, can cause this thing. I have also said donepezil can cause hypersexual behavior. Lamotrigine can cause hypersexual behavior. Number of psychiatric disorders, and I'm sure there might be some medical conditions in which we see hypersexual behavior. I have seen more depression and decreased desire in most of the medical conditions. Depression is very, very common. I'm not able to recall any hypersexual behavior associated with medical conditions, but if any of you have seen increased behavior, maybe steroid induced, steroid causes little bit euphoria sometimes, or anti-tuberculosis drugs usually causes depression, but INH psychosis, and there may be little tinge of hypersexual behavior, as somebody has mentioned that not only in mania but in schizophrenia also sometimes we see hypersexual behavior. Drug addiction, obviously, how can we forget? Weed intake causes a hypersexual behavior. Cocaine can increase the desire to indulge in sexual activities. So a variety of drugs which people take, and many people take this weed, particularly cannabis, to increase their desire to indulge in sexual activities.
Right, sir.
Yeah, Ranjan, हम भी आपको
Yes.
help कर देते हैं थोड़ा सा.
Sure.
So there are two questions regarding the role of lithium. When patients are not manic, what is the role of lithium in managing hypersexual behavior?
Okay, to the best of my knowledge, lithium is a very, very effective drug for euphoric mania, and it has a very good role in mania, 70-80% success rate. If hypersexuality is not related to mania, then I doubt whether lithium will have any role in otherwise hypersexual behavior. Say, for example, sexual addiction. We usually use counseling, behavior therapy, and a medicine which may be useful is naltrexone. To what extent lithium may be useful, I'm not very sure in non-mood disorder related hypersexuality.
So there
Sorry,
are
what?
three sorry.
Yeah,
My request-
sir, how should we go about in a workup of the case? How should we approach the case with a person who is having hypersexuality as a core symptom or as an add-on symptom? So how should we go about working up the case? What are the steps? What are the things not to be missed in the workup?
Okay. So one very, very important thing is the history. History would be the most important thing, seeing that whether how exactly the hypersexual behavior started. That is the most important thing. For example, patient had a diagnosis of ADHD. But then when he had ADHD for 2-3 years, he had never indulged in hypersexual behavior. And now he was showing hypersexual behavior. That should strike you that, oh, this is something different. This is not part of ADHD, but we are dealing with something else. And there you might see that, oh, apart from this, he has other symptoms of mania. So one, the history of hypersexuality, origin, duration, progress. Second, the concomitant other symptoms, whether hypersexual behavior is the only symptom or there are other symptoms. Based on that and your clinical examination, what we call mental status examination, you come to the diagnosis. Now, if your diagnosis is say mania, hypomania, obsessive compulsive disorder, and you think that hypersexual behavior is one of the clinical symptoms of this particular disorder, like say a symptom of schizophrenia or mania or obsessive compulsive disorder, you treat that disorder and probably all the symptoms, including hypersexual behavior, will come under control. If you think that hypersexual behavior is independent of a particular disorder, means it is not related to that disorder and it is a disorder in itself, like say porn addiction. So hypersexual behavior is a part of primary hypersexuality. Hypersexual disorder is the diagnosis. In that case, your approach will be a little different and you will treat it as a behavioral addiction. And finally, drugs. And if you feel any of these drugs can explain the hypersexual behavior, particularly if that behavior has started after taking that drug, reduce the dose or stop the drugs and see whether it is related. I don't think any investigations are necessary. Usually we don't do any investigations or workup in that case. Mainly history, mental status examination, coming to a diagnosis should be sufficient. Serum prolactin level is one of the tests which you may do if you think it is related to drugs.
George, you were asking something.
Yes, sir. So we can club these three questions, sir. One, Dr. Anil, question is learning disability with hypersexual behavior. And there is one from Saima Banu, how to treat an intellectual disability patient with hypersexuality. And there is another question, sir, similar from Jimli Chatterjee. What specific medicine or behavioral therapy techniques can be used in mental retarded children with hypersexual disinhibited behavior towards female family members?
Yes, I will answer all these questions. My humble request to all the panelists and senior members of this group to contribute, because I'm very, very sure that based on my experience, I'm contributing it, but all of you also might have seen similar cases, come across similar cases and also treated these cases. And I think you also contribute. It will be useful to everyone. It will be beneficial to the whole group. I see some 200 participants. So I think very, very important question. And we all have seen hypersexual behavior in intellectually disabled children, slow learners, or those who have severe intellectual disability, usually when they come in adolescent. So by 12, 13, 14, when the hormonal changes starts, they start developing secondary sexual characteristics, the hypersexual behavior starts. Now, usually in this kind of situation, we differentiate whether it's a normal physiological sexual activity, which the person, because he has less intellectual capacity, he doesn't know how to express it. And many times parents bring and say कि वो सबके सामने ऐसा he's touching his genitals or trying to masturbate or goes near to the sister or mother and tries to hug in a little sexual manner. Now here it may not be actually hypersexual behavior, but a normal expression of his sexual behavior. And because of his intellectual disability, he doesn't know how to express the sexual behavior. In that case, I would suggest that the parents, particularly the father, if it's a male child, or a mother, if it's a female child, to kind of explain and tell that, yes, this is not an abnormal behavior, but this is a physiological behavior. All of us have desire to indulge in sexual activity, and when we were also adolescent, we had this desire, and depending on your circumstances, depending on your knowledge, depending on availability of privacy, we have indulged in masturbation. Similarly, they should be taught to satisfy their desire to indulge in sexual activity in a socially acceptable manner. So if he is doing it in full public view, he should be told that, yes, I understand that you like doing this, you enjoy doing this, but it may not be a good idea to do it in front of everyone. So let's go to the toilet in a private room or somewhere where you can satisfy your sexual behavior. The way we get hungry, we get thirsty. Similarly, all of us get hypersexual desire, and obviously intellectually disabled children, male or female, are no exception to that. They also get desire to indulge in sexual activity, and they should be socially acceptable ways to fulfill their sexual desire. Now, if it's an excessive sexual desire, hypersexuality, that means excessive desire, that we'll have to really check whether it's an excessive desire or it's a physiological desire. But if you feel that, yes, continuously, excessively, more than expected, more than can be physiologically explained, he has sexual desire, then yes, we will have to use some medicines. I have mentioned SSRI reduces the desire. Drugs which increase prolactin, many antipsychotic like risperidone, amisulpride, reduce sexual desire. And finally, even certain hormones like ethinylestradiol, linaloral, which we use, reduces sexual desire. So all these three group of medicine, depending on what the context is and what are the other additional symptoms, can be used in these children.
Sir, with your permission, sir.
Yes, yes, please.
So many times, sir, in my practice, particularly when we see these children with autism,
yes,
and ADHD, sir, many times I feel sometimes either of the parent, sometimes they overreact to this because it becomes a stigma. So as you said, sir, making them understand what is this behavior, and then teaching the child this kind of practice in a private, and more the biggest problem is the parents feel the pain of cleaning the garment. So that's where I try to tell them that first teach the boy to use privacy, and then cleaning up the after use cleaning up thing. And most important, sir, these children should be dealt like normal children. It's if it was the same boy with average intelligence, he would have been smart to use privacy. So there many times the problem is addressed better, I feel, sir, sometimes.
Absolutely, absolutely.
Yes, just to add on, I completely agree with Dr. George Reddy. The model we commonly follow is the ABC model, the antecedent, behavior, and consequences. So if we can just follow this model and we can appropriately do the behavioral therapy, it will immensely help. In continuation of that, a question has been asked by Dr. Ravi V, that is it ethical to prescribe hormonal treatment for hypersexuality? Need any consent from the family members or patient? With that, I would like to add on one more question, sir. Is there any role of aversion therapy currently? Over to you, sir.
Okay. Any therapy which we give after explaining to the patient and the relatives whenever possible, and taking informed consent with a thing that we are doing this in the best interest of the patient. So according to me, see, whenever we prescribe, say, for example, hormonal therapy, linaloral, ethinylestradiol, I tell the relatives, I tell the patients that I have tried certain medicines, it is not working out. This is one of the options which may help the patient, and it will reduce his hypersexual behavior. and it has its own side effects, but we'll take care of it. And some side effects like little bit gynecomastia, which is not very harmful, we may have to take care. And I have personally used lineural, that is ethinyl estradiol hormone, in some patients, young as well as little elderly patients having hypersexual behavior. So I personally use it after taking consent from the relatives, explaining the nature of the treatment, purpose of the treatment, and in the best interest of the patient. So for me, there is no ethical dilemma as such. The way we use antipsychotic, antidepressants, we can use even hormones for the appropriate treatment. If somebody is hypothyroidism, you will give thyroid hormone. So if it's a hypersexual behavior because of which he comes in the under problem, then why not use appropriate treatment? It may be hormonal, it may be non-hormonal.
Yeah, sir, should we also involve endocrinologists here?
Yes, if you are not comfortable using hormones, yes. When you are not very comfortable, then yes, you can definitely say, for example, I would say when there is a increase in prolactin level and there is a amenorrhea, there are some psychiatrists who would refer them to a gynecologist or an endocrinologist. There are some psychiatrists who would say, no, I know it is induced by risperidone, it is induced by amisulpride, I will change the medicine, I will follow up the patient, and in majority of the patients, you are able to handle it. So if you are comfortable handling it, you are able to manage that patient, you may not want to send him to endocrinologist or a gynecologist, but obviously, yes, when you are not confident or you feel there is something more. So prolactin high is not only because of medicine, but even after stopping the medicine, there is a high prolactin. He has a pituitary adenoma. Obviously, you will have to send it to a gynecologist or an endocrinologist before you kind of jump onto starting carbidopa or some other kind of medicine.
Yes, sir, because what I think is any libido lowering agents if you are trying. So if you are taking consent from the guardians, suppose the patient then gets after you that you have destroyed a part of me, and then I think it would be a ethical dilemma and maybe a
yes,
legal one also.
So wherever patient is able to understand the nature and purpose of treatment, consent should be taken from the patient. For intellectually disabled patients where they cannot understand, or elderly patients with dementia when they cannot understand, consent from the guardian should be taken, and I fully agree with you.
Back-to-back questions asked by Dr. R. Raj and
Sir,
Dr.
moving
Sen.
on with that question.
Yes, Amrit, go ahead, please. Yeah, so two back-to-back questions have been asked by Dr. R. Raj and Dr. Sanjay Kumar. How long do you use the hormonal treatment, and is hypersexuality is a ground of divorce?
Okay. My simple answer to how long we use a particular treatment is as long as required. So if the patient has hypersexuality, I start the hormonal treatment and I hope that it will recede. I continue it for say a month or 2 or 3, and then I start reducing the dose, and I try to maintain the patient at minimum dose, maybe on alternate days or once in 2 days, etc. And if the hypersexuality has subsided completely, I stop the hormone and see. And if there is no re-emergence, then it's fine. But it can be continued even for a little longer period of time. We have continued for more than 6 months in some of the patients with hypersexual behavior. So hormonal treatment can be continued depending on the necessary as long as required. Of course, when you want for a very long time, then you may have to take other precautions, and you may want to consult an endocrinologist if necessary. The second question, which you said, what was that?
Is hypersexuality the ground for divorce?
Ground for divorce, okay. If it is untreatable, I think it can be a ground for divorce. But if it is a treatable, say for example, patient indulges in hypersexual behavior due to some conditions like bipolar mood disorder or obsessive compulsive disorder, and you treat that disorder, it is correctable, then probably it will not be a ground for divorce because it can be treated. But even after treating for say 1 year, 2 years, and there is no improvement, and as a result the spouse is suffering, then yes, it can be a ground for divorce. But we will have to prove that yes, it is a disorder and it is not treatable. So even after taking adequate treatment, patient has not shown adequate improvement. So on the ground of hypersexuality, yes, you can file a case for divorce.
So, moving on, sir. Sir, if somebody is hypersexual and somebody is not amenable for treatment, he tells, I will not take your risperidone, I will not take the hormones you are giving. You have no right to do it. So now do we move court? If somebody is having problematic behavior, somebody is indulging in, suppose pedophilia, somebody is indulging in a lot of activities which is creating a lot of distress, and the guardians want us to treat him for that. Now what should we do? Should we move court, or should we just wash our hands until you get an order from the court, then only we'll proceed?
No. See, we should go all out to help the patient in the whatever best possible manner. So now, if say there is a boy with conduct disorder and he is repeated sexual offender and is doing all these things, obviously we can guide the patient's relatives that yes, he is doing this, this is not desirable, this is not acceptable. So you have various options. So options is one, they can lodge a police complaint. Police can say that yes, this is not desirable, and either depending on his age, he can go to children's home. At least in Mumbai, we have children's home where these children are put. He can be put in a rehab center. And yes, of course, the parents can file a petition in the court. And as a psychiatrist, we can give a report saying that yes, this is a disorder, and for this, some treatment should be done against his will and with the permission of court. He should be stopped from indulging in hypersexual behavior, which is not only harmful to himself, but also to the others, to the people, society at large. So it has to be done.
Question asked by Dr. Pranav Vaidya. Respected sir, any role of other biological modalities like transcranial direct current stimulation, repetitive transcranial magnetic stimulation, or ECT in excessive hypersexual behavior?
Okay. Primarily, the answer is no. I'm not a RTMS or a TDCS man, but if it is a part of, say, for example, hypersexual behavior is a part of mania, and mania is not getting controlled with your antipsychotic, anti-manic mood stabilizers, you can use ECT to treat manic episode in which hypersexuality is a symptom. So yes, that way ECT can be used if it's a severe depression with atypical depression with hypersexual behavior. Yes, treatment-resistant OCD, some people have tried ECT, so in that you can use it. But only for hypersexual behavior, I don't think any of this treatment, at least to the best of my knowledge, I have not come across any cases, or I have not used any of this behavior, any of these treatment modalities. But anybody who has used like TDCS or RTMS for or ECT primarily for hypersexual behavior, yes, they can contribute.
Yes, sir. In elderly with cognitive decline, I think what I find is a very difficult to treat group. We all must have seen some other patient. One patient I had, the son came and बहुत शर्माते हुए उसने बोला कि sir, father, what his father was doing, it was actually caught on CCTV. He was exposing his genitals to the dogs on the street, offering them food and them giving his private parts for the dogs to lick them. So I think we all must have encountered all such cases. So in cognitive decline, elderly patients, what has been your experience?
Yes. See, sexual desire remains throughout the life. Sometimes you get 87 years old patient saying that sharam ki jagah naram hai. So that is not unusual. And obviously we respect that, yes, at any age you can continue to have sexual desire, and it has to be fulfilled and preferably in a socially acceptable manner. Now, suppose some elderly person in his house is indulging in little bit sexual activity with a dog, and the dog doesn't mind it. It is not cruelty to the dog. It is a pet dog, and nobody wants to record it on the CCTV, and it is not very harmful. I will not be very kind of to quote, see it as a moral thing that it is not good or it is wrong. In a way, he's fulfilling his sexual desire. Wherever possible, you should help them. So if he's masturbating, say 87-year-old or 85-year-old, 82-year-old female, if she's masturbating, yes, they can be allowed to do that in privacy so that they can fulfill their desire. But we are talking about hypersexual behavior. It is very excessive. Then obviously it requires treatment, and variety of treatment, SSRI, amisulpride, lineural can be used for the treatment, the way we would use other methods.
Yeah, do these behavior interventions work? Suppose in BT, behavior therapy, we replace one target behavior with another behavior. So does this work in these cases in hypersexual behavior?
For example, how would you replace masturbation with what?
Yeah. So do we have any option for that?
So see, sexual pleasure is very unique. So see, if I am a diabetes and I am not allowed sugar, I can use sugar free to make my tea sweet. So that is the option. Now, I immediately do not think of any replacement for sexual pleasure, the pleasure which you get by masturbation or by indulging in sexual activities. The only, like we are in a technical era or a computer era, and nowadays there are dummies, artificial women, models which are available, or these gadgets are available by which you can fulfill your sexual desire. So fine, you can use those things, the certain gadgets which are like vibrators for female and certain kind of things which males can use. So yes, that can be a substitute.
Sir, over the past decade, there have been an exponential growth of the pornographic website.
Yes.
The question asked by the Dr. Bhupinder Ji, that what is the treatment in people with having the excessive pornographic use when they are maintaining normal sexual relationship amongst them?
Okay, so we are talking about addiction, and the way people can have alcohol in a socially acceptable manner, and in most of our conferences you will find one odd person who gets he cannot control his alcohol, and then finally at the end of the conference at 1 o'clock in the night, people have to help him, friends have to help him to go to the room. So that's an addiction that he is taking excessively. Similarly, indulging in sexual behavior is absolutely normal, but yes, watching pornography is absolutely normal. I think we all get on WhatsApp one pornographic little small slit or a joke or a video film every day, and we all watch it. Let's accept it. So if it is like that, I don't think anything wrong in it. Let's not make it moral judgment kind of thing. But yes, if you are glued to this pornography to such an extent that as a result you are not doing anything, there is a deterioration in your psychological, social, occupational functioning, then yes, it's a behavioral addiction. And one of the medicine which we have found to be useful apart from these medicines is naltrexone. And naltrexone works very well for behavioral addiction. So you can always try naltrexone. You start with 50 milligram, go up to 150 milligrams per day. And there are case reports where they have found that pornography addiction decreases with naltrexone, the way other addiction also decreases with naltrexone.
Two interesting questions, sir. One question. I'll just clubbing both the questions, sir. So one is, can hypersexuality be taken as a plea for sexual offenders? Can it be taken as a plea by sexual offenders? And the number two is, what is the criminal responsibility of people who are hypersexual?
Okay.
So both sides.
Yeah, two things. If it is hypersexual behavior is a part of very well understood psychiatric disorders like mania, bipolar mood disorder, person takes a loan which is able to not able to repay the loan. We give a certificate that when he took the loan, he was not in a proper state of mind. He did it when he was mania. So that contract or whatever thing should be considered as invalid. And same holds if he has indulged in hypersexual behavior or touched some lady or tried to be more friendly with one lady under when he was manic episode. Yes, as a psychiatrist, we should help him and say he has done it when he was mania and he has not done it intentionally. So he should not be penalized. So for mania, yes. For schizophrenia, yes. The problem comes with personality disorder. So if somebody has antisocial personality disorder and he indulges in stealing, lying, gambling, shoplifting, and if we say, oh, it's a treatment, he has a conduct disorder, that's why he's indulging in it, not accepted. Because the treatment part itself includes that there should be some deterrent so that he doesn't indulge in similar behavior again and again. So if hypersexual behavior is a part of antisocial personality disorder or some personality disorder and knowingly he has indulged into it with a full intention, then probably he will not get any relief from the sentence and he has to serve the sentence probably if, let's hope that that sentence will act as a deterrent for him to indulge in similar behavior next time. At least it will keep him away from the society and protect the society from him who is indulging in this kind of behavior.
Sir, he has no other issues, no personality issues, nothing. The only behavior which is maladaptive, which is dysfunctional, is the hypersexuality.
I would
Now,
like to suggest.
Suppose, yes, sir.
Yes, sir.
I would like to suggest in this regard. There are two aspects in this issue. Number one, whether the person, whatever disease he is suffering from, is understanding that this act can lead to these damages and it is a punishable act. Then if he understands in spite of all the symptoms, he is punishable.
Yes.
Second
yes.
most important point is that how his statement is considered by the concerned judge. That is most important because we have seen in the last 2 years many things. The whole thing has broken down because the understanding by one particular judge is different, which again gets modified in our cases. So these are two things, and we psychiatrists are always at loss or at risk. We do not know what, in spite of giving the best advocate to our defensive if our decision is challenged, what that particular judge conceives. When 1987 Mental Health Act was there, I had discussed with many legal persons. None of them had gone beyond 1912 in Enlonage Act. And that is why it was not implemented in most of the states. As Supreme Court observed in 1999, 12 years after the enactment. So that is another important fact. So when you take steps in these cases, one has to be very much cautious. Clinical enthusiasm versus the possibility. And these people can be notorious at some times because we have seen among psychiatrists being implicated for nothing. And another thing, an hypersexual patient, when he is with a therapist, not necessarily with a psychiatrist, and there is a development transference, it can be utilized or misutilized by the members of the family. There's a great risk. So legality has to be taken in right perspectives. And if the patient understands the things in spite of having a schizophrenia, then he can be punished. Nothing matters. Schizophrenics has been always not given the favor in divorce suits also. He is having schizophrenia, he will have a divorce? No, nothing. He may not have it. That depends on what we are going to prove about his capacity to understand and how the judge interprets our pleading and the opposite party's pleading. Ultimately, वो वहाँ चला जाता है जहाँ हम नहीं होते.
Rightly pointed out, sir.
Thank you, sir. Sir, I think it's 9:30. We'll call Dr. Nilesh for another session. Closing remarks from the chairpersons, Dr. Ranjan and Dr.
I think, Amrit, there are so many others who ask questions. I think due to paucity of time, we'll not be able to take their questions. Sorry for that. Yeah.
Yeah.
And there could have been a lot of
Uh,
questions because there is another aspect that we have discussed about many things, but we have not discussed about the hypersexuality of transgenders as patients. What is the clinical relevance of that? Dr. Nilesh will speak in the next meeting, I think. And I don't want to go into the time limits.
And maybe
And
maybe
I-
we'll take a session on psychological aspects of treatment of hypersexuality. Acceptance and commitment therapy, sort of things. Maybe next time we'll pick up something. Sir, over to the chairperson, sir.
Yeah, thank you, Amrit. It has been a wonderful 90 minutes experience. It's a wonderful journey with such a beautiful background and of the Nilesh sir and the stalwarts in the forefront who are the accompanying chair, my co-chairperson, the organizing chairperson and organizing secretary. The time has elapsed beautifully. We couldn't pick up all the questions, and as mentioned by the organizer, there'll be one more session in the coming days. So with this, I would like to end up and I'd like to hand over the microphone to my co-chairperson, Dr. George Reddy, for his brief remark.
Yes. Thank you, Dr. Ranjan. I think it was a splendid session, sir. I think the time rolled and you made the presentation so lively, sir. I think so many inputs from your personal experience, and I think definitely all the viewers would have got a lot of new inputs and will help their daily practice. Particularly, I took this point, sir, use of naltrexone in addictions, behavioral addiction. I think that's a very good take-home point for me, sir. Thank you, sir. Over to the organizing team.
Dr. Tufan, sir.
So I have already made my statement, and I sincerely thank Dr. Nilesh for having graced this occasion. And this topic was actually, when we discussed, he has coined this term, coined this topic. And thanks, Dr. Nilesh, for coming and deliberating on this topic.
My pleasure.
And thank Dr. Ranjan and Dr. George for chairing the session. And I can present you nothing but the baby of girls behind our speaker. That photograph is for you. And thanks, everybody.
Thank you, sir.
On behalf of IPS, I would like to give a formal thank you. Dr. Nilesh Shah, the hero, you always find him in Goa. Even if he's putting around in the intensive care unit, he will be in his splendid shirt, beautiful babes, and it was a pleasure hearing you. Dr. George Reddy, thank you so much for coming. Dr. Ranjan, ever energetic, brilliant. Aleem has been quiet for a change. Dr. Tufan sir for bringing some other topics which will come out in the later sessions. Thank you, our audience. We had more than maybe 300 people logged in. 240 was the highest. That was brilliant. Maybe 400 registrations. Thank you for all our participants who have always been active. And I think that it is not only sex that pulls, it is the speaker who also pulls. Like sir told, hypersexuality, his sexual preference is often, but for most it is when we get. So we are sexual by beak, not by when we want it.
Honest confession.
Thank you, Pawan. Thank you, everybody. Thank you, IPS OSB, for helping us, for supporting us. Next time, we'll come up with another brilliant session. Good night, everybody. Thank you so much.
Good night. Thank you.
Good night.
Thank
Good
you
night.
so much, sir.
Thank you, everybody.
Good night.
Good night. Good night. Bye-bye.